Hello everyone, my name is Steven Braccioforte and my project is on diseases of the respiratory tract. I chose this topic because I have experienced many of these problems throughout my life. I also work with an ear, nose, and throat physician and felt it would be both informative and exciting to understand more about these diseases. Hope you enjoy my presentation. An infection is noticed if fluid and inflammation are present in the middle ear. This is known as acute otitis media. This eventually leads to blockage of the eustachian tube, which does not allow bacteria to be drained. This disease can be viral or bacterial, but most cases are bacterial and occur in children between the ages of 1 and 3. The reason children experience these infections is due to the fact that their eustachian tube is a lot smaller and more horizontal compared to adults. Streptococcus pneumoniae is a gram-positive commensal microorganism of the respiratory tract and the causative agent for acute otitis media. Haemophilus influenzae and Moraxella catarrhalis can also result in acute otitis media. Although less common, adenovirus and rhinovirus are some agents in the viral aspect of this disease. The pathogenesis of this bacterium involves 4 steps that can lead to a middle ear infection. The first step would be portal of entry. Microbes enter the mucous membranes of the respiratory tract through inhalation of aerosols or direct contact. Then adhesion would occur, where microbes stick to the mucosa of the nasal cavity and colonize. Once colonized, these microbes invade to surrounding tissues and cells, leading to infection of the eustachian tube. This infection is not long-lasting and will most likely resolve on its own. Some symptoms people experience with acute otitis media are ear pain or even ear pressure. This is from the buildup of fluid and inflammation that is present in the middle ear. Discharge from the ear can be from the eustachian tube opening up and allowing the fluid to drain properly. As for fever, this can indicate the body fighting off the infection. Fever impedes the growth of bacteria. Loss of balance is a symptom because your inner ear is the origin of balance. Being close anatomically to the middle ear, loss of balance may be a symptom that correlates to AOM. The photo on the left is an example of a middle ear infection. You can see the inflammation and the redness around the tympanic membrane. The photo on the right is a normal tympanic membrane, so you can compare. A clinical presentation will diagnose acute otitis media. An otoscope is an instrument that physicians use to view your tympanic membrane and ear canal. It helps identify inflammation and even fluid behind the tympanic membrane. Tympanometry is a method used to test the mobility of the tympanic membrane and the conduction of bones by creating variations of air pressure in the ear canal. Reflectometry is when a physician will blow a sound wave in the ear canal and determine if the tympanic membrane consists of fluid. Lastly, you can obtain a culture of fluid and determine the species of bacteria. This illustration is a graph of an audiogram with an individual who is experiencing hearing loss. Hearing loss is identified when the peaks are absent. If someone who is not experiencing symptoms of hearing loss, there would be peaks present indicating no fluid behind the ear. A study was performed that consisted of 615 children during the age of 6 and 36 months for a time period of 10 years. Results showed 23% of children of 1 year experienced less than or equal to 1 infection of acute otitis media. By 3 years of age, 60% of children experienced 1 episode of AOM, and 24% of children experienced less than 3 infections. The peak occurrence of infection was between 6 to 12 months of age, and risk factors included white males in a daycare setting. With the close environment the children have to each other and their immune systems not responsive to certain strains of bacteria, it is easier for bacteria to infect. Other risk factors that are beginning to rise in studies is the exposure to tobacco smoke, as it increases susceptibility to pneumococcal infections. There are ways to treat acute otitis media. Most physicians would suggest surveillance in a young child due to spontaneous resolution, along with anti-inflammatories. If pain and severity increases, doctors then prescribe amoxicillin or Augmentin. Hydrocortisone ear drops are also helpful. If a patient is chronic, there is a surgical option that can be performed. Myringotomy tube placement is a procedure that allows the fluid from behind the tympanic membrane to drain. Bacterial sinusitis is another disease of the respiratory tract. This disease originates from a viral infection and can lead to a secondary bacterial infection. About 98% of cases of bacterial sinusitis originated from a viral origin. Bacterial sinusitis is an infection residing in the sinus cavity. This infection leads to inflamed sinus cavities and blockage of sinus ostia, which is a small opening between the sinus cavity that allow airflow and the drainage of mucus. This disease is associated with the common cold. The viral agent most commonly affecting individuals that leads to bacterial sinusitis is the influenza virus. Some strains of rhinovirus and adenovirus can lead to bacterial sinusitis as well. The viral infection can lead to inflammation of the sinuses that can resolve around 10 to 14 days. If symptoms last longer, this indicates a bacterial infection has developed. This most common bacterial strain of infection is Streptococcus pneumoniae. Strains of Haemophilus influenzae and Moraxella cotartalis can be responsible as well. This picture indicates the anatomical positioning of your sinuses. During an infection, the nasal mucosa produces mucus and calls white blood cells to the area, leading to congestion and inflammation of the nasal cavity. This prevents the cilia in the nasal cavity to perform less efficiently, promoting bacterial growth. The pathogenicity of this bacterial strain consists of several steps leading to bacterial sinusitis. First is portal of entry. The microbes enter through the nasopharynx from aerosol droplets or from direct contact. Second step is adhesion. The microbes will stick to the nasal epithelium and colonize, causing the blockage of the sinus ostia. The bacteria will continue to grow, building up mucus in the nasal cavity, promoting bacterial growth. Spreading then occurs and is transmitted from direct contact of an infected individual or indirect contact from an inanimate object, causing infection in that host. This picture shows what is called sinus disease. This is when you have a buildup of mucus and inflammation in the sinuses. Some symptoms of bacterial sinusitis include congestion, postnasal drip, runny nose, and brown or yellow discharge indicating infection. Another symptom of sinusitis is pressure around the forehead, specifically near the eyes and cheeks. These specific places are where your maxillary sinus and your frontal sinus are located. Foul smell or taste is another indicator of a bacterial infection. When someone presents in clinic with sinus pain, there are other factors that can affect this infection as well. Some examples commonly seen in the clinic are anatomical factors like a deviated nasal septum, which curbs airflow in the sinus cavity. As there are anatomical features that accumulate infection, immunodeficiencies can also promote bacterial sinusitis, including selective IgA deficiency, which protects us against infections of the mucous membranes. This illustration may be silly, but actually does well combining all aspects of bacterial sinusitis into one. The physician will diagnose sinusitis during a clinical presentation, based off the patient's history and the physical examination. If further examination is necessary after noticing purulent discharge, there is a non-invasive procedure called a nasal endoscopy that can be performed. This procedure consists of a telescope attached to a thin probe that will allow the physician to see your nasal pharynx more clearly. In some cases, a patient could be considered chronic, leading to the physician to obtain a CAT scan of the sinuses that will show any disease in any of the sinus cavities. Bacterial sinusitis complicates approximately 5% of studies of upper respiratory infections. A study was performed on the incidence of bacterial sinusitis. Results varied between seasonal and geographical applications. Around 15 to 40% episodes per 1,000 patients experienced bacterial sinusitis per year. A study from the National Ambulatory Medical Survey states the increase in incidence. A study performed in 2001 diagnosed 13.6 million outpatient visits with sinusitis, according to the CDC. In the United States, 40 million Americans are affected by sinusitis every year, and 33 million cases of chronic sinusitis are reported annually. Bacterial sinusitis has many treatment options. Many people don't realize that allergens can cause bacterial sinusitis as well, and are urged from the patient to cleanse their home to signify an allergen. Nasal supplements are also a means of treatment. An example is Neomed saline rinse bottle. That helps inhibit bacterial growth. Others are Flonase and Propel, which are nasal steroids. A physician may prescribe Augmentin to a patient who is chronic. There is a surgical option as well called a FES, a functional endoscopic sinus surgery, where the purpose is to restore sinus ventilation. The last upper respiratory tract infection I would like to discuss is pharyngitis viral. Pharyngitis viral is associated with a viral infection of the respiratory tract. It is an infection that resides in the pharynx and can lead to tonsillitis. These pictures identify normal tonsils that compare to someone experiencing enlarged tonsils. The causative agent in pharyngitis viral is the influenza virus, commonly known as the flu. The flu can be a very dangerous virus if not treated or not vaccinated. Other agents include adenovirus and rhinovirus that infect the upper respiratory tract as well. This disease can cause some very serious problems, as we have witnessed in our recent past. The lack of vaccinations received can lead to an outbreak of such and ultimately endanger many people. The steps for pharyngitis viral include portal of entry, adhesion of microbes, surviving host defenses, and spread of infection. The portal of entry is the first step and starts infecting in the respiratory tract through direct contact of an infected individual or aerosol droplets. Then the microbes stick to the epithelial cells of the respiratory tract, leading to infection of the pharynx. The virus survives through a process called endocytosis to bypass the immune system from eliminating it. To continue with infection, specialized enzymes called polymerase are released to trick the host cells to replicating the viral genome, spreading infection to other individuals. Symptoms that people can experience when contracting influenza are fever, fatigue, and enlarged neck lymph nodes. This means your body is in works of fighting off an upper respiratory infection. More specific symptoms towards pharyngitis viral are throat pain, sore throat, swollen tonsils, and a cough. Dysphagia, which means trouble swallowing, is also a symptom of pharyngitis viral. These symptoms do tend to resolve on their own unless complications have emerged. A clinical presentation is necessary to properly diagnose someone with pharyngitis viral. One method to diagnose this infection is to obtain a culture to rule out bacterium strain. Another method to diagnose someone is to perform an indirect laryngoscopy. A mirror is used to identify certain areas of the throat that one cannot see during a regular examination. A sign of pharyngitis viral is enlarged tonsils and sore throat. However, if further diagnostic measures are needed, a physician may perform a laryngoscopy, which is a view of the throat from a telescope that enters through the nose. Study shows that the most common cause for pharyngitis viral is direct contact, although indirect contact is possible as well. This virus accounts for the top 20 diagnoses and office visits. The peak occurrence of infection is in childhood and adolescence. A recent study shows 1.1% or 12 million ambulatory visits were diagnosed with pharyngitis viral. Another study mentions that the peak occurrence is between late winter and early spring, exemplified by this graph. This viral infection will most likely subside on its own within 7 to 10 days. Antibiotics are not always prescribed for this reason. Instead, pain relievers are suggested to help for the remainder of the infection. Patients should use saline rinse gargles and increase fluid intake to help the body fight infection. In future cases, one should also obtain a flu vaccine, as it will prevent the infection to return and will limit a possible outbreak of the infectious agent. That concludes my presentation. I hope you all enjoyed it and have learned from it as well. Thank you.